Hello?
Done.
Done? Okay.
Yes, ma'am.
Right. Very good morning, guys. Very good morning, guys. Welcome to the platform of eGurukul and Dr. Bhatia Medical Coaching Institute. I am Dr. Ramyasree. So, I will be teaching obstetrics and gynecology for all of you. So, obstetrics is a pretty simple subject which can be made as your strong subject. This has to be made as your strong subject so that you can get a perfect score in your exam, right? And most of the time we almost get 30 questions from obstetrics, right? And how much you'll read about obstetrics? Only about uterus, right? So definitely you can do it, right? I'm going to teach it in very conceptual manner. I'm going to teach it in a manner by which you can retain in your brain. So you're going to learn it in a retainable manner, crisp notes which can be easily reproduced back. I'm going to teach all the updates. So whatever I'm going to teach now is as per Williams 26th edition and Williams 4th edition of Gynec. So it will be all updated version. And I have made plenty of mnemonics to remember the things easily. So it's going to be a combination of everything. At any point of time, if you don't understand anything or if you are feeling like, something which you couldn't understand, feel free to ask. Now only thing which you have to give me is I am ready to give 100% and I want you also to give the same 100% in the class. So just try to grasp maximum in the session itself. So 80% what you're learning, try to grasp it here itself. And every day post class, just go back and revise the notes which I'm providing to you, right? And see to it that the next 3 days gap may you finish off entire obstetrics. So whatever the timeline provided to you for obstetrics and gynecology, try to finish it in that itself and try to solve MCQs. Yes, I've also curated some beautiful MCQs, so we'll solve those MCQs also so that you become perfect with OBGYN, right? So let's start with it. I hope you're all also ready for it. Okay, now one more thing is that I have provided the PDF. Now it's always the PDF I have put in such a way that I try to make it as a where you can write it also in the PDF. So if you could take out a printout, it was definitely good. If you have not taken printout also, don't worry, you can write in your notes. But yes, I think it is more easy for you to take a printout and write it in it. But it is like lot number of pages, so just have a balance of it. Okay. Okay. So I want all of you to be very active during the session, participate in the questions and try to answer the MCQs which I am discussing. That way your flow will be maintained and you will remember things more better if you're committing any mistakes here, right? So very good morning to all of you. Very, very good morning to all of you. My first question to all of you is, who are very complicated, boys or girls? So I'm going to start with basics of reproduction. That is, how are the gametes formed? So I'm not starting here with anatomy and embryology. I'm starting in obs with basics of reproduction. When I go to gynec, I'll start with anatomy, embryology and physiology. I have my way of teaching and I assure you, if you're perfect with the notes provided by me, you can aram se crack the exam. There is no doubt in that. So whatever the notes I'm providing you, if you're 100% perfect with that, one or two questions nobody can help, but rest like 28 out of 30 to pakka you can aram se get. Okay, so don't at all worry like this that you will everything will be covered, but my way of teaching is different from others. That's the only thing. Okay. Right. So who is very complicated, girls or boys? Yeah, I also agree. Girls are a little more complicated compared to boys, right? So if we see the oogenesis and spermatogenesis, spermatogenesis is pretty simple, but oogenesis is little difficult. So yes, girls are a little complicated. Even oogenesis is also complicated. Now first, to start with the gametogenesis, first, how does this germ cells arise? Let's understand first how does this germ cells arise. Now, first question I would like to ask you is, from where does the female genital tract is developing from? So the female genital tract or the male genital tract develops from intermediate mesoderm. So this develops from intermediate mesoderm. So we have mesoderm, endoderm, ectoderm. So from intermediate mesoderm, you will see these ducts developing. If you are able to see, so this mesonephric duct, paramesonephric duct, all this develop from the intermediate mesoderm. So female genital tract, that is uterus, cervix, fallopian tube, and upper two-third of vagina arise from the intermediate mesoderm. Okay, but germ cells arise from the yolk sac, guys. So when they're arising from yolk sac, they are of which origin? Are they ectoderm, या endoderm, या mesoderm in origin? So germ cells arise from yolk sac. They traverse through So these germ cells will actually arise from the yolk sac, and from the yolk sac, these germ cells, if you see here, they pass through the dorsal mesentery of hindgut, and then they reach the gonadal ridge, So they are actually coming from the yolk sac. From the yolk sac, they'll reach the hindgut, and from the hindgut, they pass through the dorsal mesentery of the hindgut, and then they reach the gonadal ridge, and they're actually bipotential to start with. So that is, you don't know whether they'll become testis or whether they'll become ovary. Again, this in detail I'll be discussing in embryology while I'm discussing the gynecology. Okay? So they traverse through dorsal mesentery of hindgut to reach gonadal ridge. So my question, I asked you one question. Key germ cells are what origin? So as they are arising from yolk sac and they are passing through the dorsal mesentery of hindgut. So are they mesodermal in origin or are they endodermal in origin? So germ cells are endodermal in origin. Germ cells are endodermal in origin. So I think you all got this question in the INECET that bipotential gonads are differentiated by SRY gene, which is located on short arm of Y chromosome, right? So again, as I already told, I'll be discussing that in detail in gynec. Very good, excellent. I see the answers coming. So germ cells are endodermal in origin. So now, these germ cells, depending on whether it is testis developing or ovary developing, they will undergo gametogenesis. First, I'll start with spermatogenesis. As we have already discussed, boys are a little simple. So spermatogenesis is also simple, right? Now, what is the MCQ asked? Every topic I'll tell you what is the MCQ asked. So the MCQ which is asked in this topic is mainly the spermatogenesis sequence. That has been asked as an MCQ many times. So you should know the sequence of the spermatogenesis. Now first, before I start with spermatogenesis, so testis has two types of cells: Leydig cells and Sertoli cells. LH, that is luteinizing hormone, will act on the Leydig cells to produce testosterone. And this testosterone is responsible for the spermatogenesis. Whereas FSH will act on the Sertoli cells to secrete androgen binding protein. Androgen binding protein. Now this androgen binding protein, this only tries to maintain, this maintains the testosterone levels. High. So it just tries to see that testosterone levels are maintained high inside the testis. So mainly it is the LH which will act on the Leydig cells, which will secrete the testosterone, and that is the one which is helping in spermatogenesis. FSH will act on the Sertoli cells to release androgen binding protein. This androgen binding protein maintains high levels of testosterone. Also, Sertoli cells help in making the blood-testis barrier. Okay. So now next, so in spermatogenesis, first we have the spermatogonium. This spermatogonium will undergo mitosis to form the primary spermatocyte. This will undergo meiosis 1 to form secondary spermatocyte. Hello. Huh. So spermatogonium will undergo mitosis to form the primary spermatocyte. That will undergo meiosis 1 to form the secondary spermatocyte. This will undergo meiosis 2 to form spermatid. Now I want you people to tell me, so if you are seeing, this is the cut section of the testis. So in the cut section of the testis, if you observe, from the testicular wall, you have the spermatogonium, and in the lumen, you have the sperms. So there was one question where they have asked what is the order of the cells from the lumen to testicular wall. So if they ask from lumen to testicular wall, it is ulta. Right? From the lumen means lumen to testicular wall, it will be ulta, no? Because sperms are in the lumen and spermatogonium is towards the testicular wall. So that you have to remember, guys. Okay. So next one thing, which is a reduction division here? Who can tell me what is a reduction division? In which step the number of chromosomes will become half? So mitosis also the number of chromosomes will remain same, but meiosis 1 may the number of chromosomes will become half. So primary spermatocyte to secondary spermatocyte, the number of chromosomes will become half, right? So secondary spermatocyte will be very good, excellent Sonu. So meiosis 1 will be number of chromosomes half. So then secondary spermatocyte will either become 23X or 23Y. So spermatid are the round cells. So this will be again either 23X or 23Y. So let us be very particular. Meiosis 1 is a reduction division, number of chromosomes becoming half. Now this spermatid, this spermatid, this has to transform to become the sperm. So spermatid transforming into sperm is called as spermiogenesis. Spermatid transforming into sperm is called as spermiogenesis. This entire process is called spermatogenesis, but the round cells transforming into sperm is called as spermiogenesis. So I'll show you how will be the spermiogenesis. So this is the round cells which is transforming into sperm, right? So if you observe here, the nucleus of the spermatid will become the head of the sperm. The Golgi apparatus will become the acrosome of the sperm. The mitochondria will become the middle piece of the sperm. And the centrioles will become the tail of the sperm. So this transformation is called as spermiogenesis. So what is transforming into what in the spermiogenesis? So the nucleus is transforming into head. Acrosome is transforming into, the Golgi apparatus is transforming into acrosome. Okay. Next, the middle piece, the mitochondria will become the middle piece. Whereas the centrioles will become the tail. So this is about the spermatid. This is sperm. Now, to be frank, I have not seen any question on what transforming into what, but yeah, better know it. But the steps are very important. The sequence is very important. Okay. So that's about the starting. Very good. So now what we have discussed is the spermatogenesis. Now let us write some single liners about spermatogenesis. So first and foremost, you should all know the sequence. So spermatogenesis may first, what was it? It was the spermatogonium. So the spermatogonium will undergo mitosis to form the primary spermatocyte. This will undergo meiosis 1 to form the secondary spermatocyte. This will undergo meiosis 2 to form the spermatid. Spermatid will become the sperm. This much, even in your dreams also, if somebody wake you suddenly, you should be able to answer. That much you have to imprint in your brain. Matlab, pakka imprintation. Okay, now, who is very bindas, jo chal raha hai, chalne do. And who is like too much, like now only thinking what is their bacha's name, what will be their bacha's education, who is too much forward thinking and who is too much who will be thinking. Boys or girls? So, spermatogenesis. I think boys are little bindas thinking like jo chal raha hai, chalne do. Same with spermatogenesis. Spermatogenesis should start when? Spermatogenesis should start at puberty. So, yes. So, girls overthink. Yes. So, for girls, oogenesis starts in utero. Too much forward thinking. है ना? Forward thinking. आगे का thinking. And spermatogenesis starts at puberty. It has to start at puberty. It starts at puberty. So spermatogenesis starts at puberty. Okay, I'll ask you one more question. You tell me. On a date, Who should wait for longer time? Girls or boys? Valentine date. Who should wait for a longer time? Girls or boys? So we are going to write the lifespan of the sperm. So boys should wait for longer time. So same way, यहाँ पे also there is a date. And where is the date? Date venue is in the ampulla of the fallopian tube. So as the date venue is in the ampulla of fallopian tube, the lifespan of the sperm is 72 hours. Girls don't wait for longer time. So lifespan of the ovum is 24 hours. I think now you'll never forget. So lifespan of the sperm is 72 hours. The lifespan of the ovum is 24 hours. Okay. The time taken for spermatogenesis is, so time taken for spermatogonium to spermatid is 72 to 74 days. Everywhere it is like 72 here. Okay. So time taken for spermiogenesis is 14 to 16 days. So on the whole, spermatogenesis takes how much time? So spermatogenesis takes around 90 days. That is why post vasectomy, how long we should have how long we should use additional contraceptive like condom? 90 days. So all of you are post interns, so I think I can combine things and speak. So usually post vasectomy, there are still sperms which were formed 90 days back. So that is why post vasectomy we wait for another 90 days before they till those 90 days they should use additional contraception like condom, or they should maintain abstinence. Better to use a condom, right? So why? Because spermatogenesis takes around 90 days, right? Okay, now next coming to one more point is, yeah, 3 months, 90 days, correct. Now one more point here is, one spermatogonium will give rise to, so one spermatogonium will give rise to 16 primary spermatocytes. And one primary spermatocyte will give rise to 4 sperms. So one spermatogonium is giving rise to how many sperms, guys? So one spermatogonium will give rise to 64 sperms. So this is all about the spermatogenesis. Now, so Dula is ready. Dula is ready, right? But the competition for the men is too much. Why? There are millions of the sperms which are formed. And how many ovum are there for these millions of sperm? Only one ovum competing with millions of the sperms. So now they have to put some extra effort. Otherwise, it's very difficult for them to win. So now this extra effort by the sperm is called as capacitation. So they have to move fast in order to reach the ovum. So capacitation is, so after the formation, so first is spermatogenesis, then is spermiogenesis. After the spermiogenesis, we have capacitation. So capacitation is, once the sperm enters the vagina, they become hypermotile because there are millions of that sperms, and in those millions of the sperms, so per ejaculate there will be 39 million sperms, guys. In that 39 million, only 2 million cross the cervix, and in those 2 million, there only one sperm which will actually become the winner. So I always tell, whenever you're scared about the NEET competition and all, Arey, you have won. We are born means we have won the competition among millions. When millions were competing, we were that one sperm which could compete and become a zygote and form us. So what is this competition in lakhs? This is like cakewalk, you know? Right. So for the sperm to win, sperm has to become hypermotile. So remember, this hypermotility of the sperm is called as capacitation. So capacitation is sperm hyperactivation, and it also attains ability to penetrate the ovum. So there will be acrosomal contents which form so that they can penetrate the ovum. That part is called as capacitation. Just remember till here capacitation. Once we finish oogenesis, there are two more things which I'll teach you. So capacitation results in sperm hyperactivation and the ability to release acrosomal contents. So where does this capacitation take place? So capacitation takes place in the female genital tract. What is the time taken for capacitation? Time taken for capacitation is 5 to 8 hours. Okay. So next, coming to the oogenesis. So now we are going to discuss about the oogenesis. So there is a lot of confusion among the students ki what is oogenesis, what is folliculogenesis, and what is follicular phase of the ovarian cycle. So I will tell you guys, all these three things are different. All these three things are different. The development of the, remember, follicle is like a balloon. Okay? Oogonium is like a marble inside that balloon. First clarity in your brain, follicle is a balloon, oogonium is a marble inside it. Development of only this marble is called as oogenesis. Development of that entire balloon is called as folliculogenesis. And this somewhere take place in one part of the ovarian cycle, that is a follicular phase. So all three are different. So follicular phase and folliculogenesis I'll be discussing in the gynec. So that time you should think, your brain should strike that okay, oogenesis also takes place here somewhere. So you should be in a you should be able to cooperate inside. But now I'm going to discuss only what is the development in the oogenesis. So we already told that woman has lot of forward thinking. That's how this oogenesis also starts at 9 weeks of intrauterine life. So this yellow color one is the oogonium, this red color one is the granulosa cells. So actually this entire thing is the follicle. So only the yellow color one is the primary oocyte. Okay, right. Now, do you want the woman to start? Do you want the woman to start having the ability to reproduce as soon as she is born? So it is starting at 9 weeks of intrauterine life. So it means she'll have the ability to reproduce as soon as she is born. So do you want it to happen? So first oogonium will undergo mitosis. Here also the same 3 steps. And it forms the primary oocyte. Okay. So the balloon is follicle. Balloon के अंदर small छोटा marble will be oogonium. I am discussing the development of that marble, that is the oogonium. So marble is oogonium, balloon is follicle. Okay. Now you tell me you really don't want the woman to reproduce as soon as she is born. So this balloon, that is the follicle, this contains the cells called granulosa cells. They are like motherly, little motherly figure. So what will that do? It will be like, nahi bacha, let us not have the ability to reproduce as soon as you are born. So what this granulosa cells do is, it produces something called as meiosis inhibiting factor. So as this meiosis inhibiting factor is released, the primary oocyte gets arrested in the first phase, that is prophase of meiosis 1. So primary oocyte arrests in prophase of meiosis 1. That too, if you want to really know in depth. So it arrests in diplotin stage of prophase of meiosis 1. Because of the meiosis inhibiting factor. Why? Because you don't want her to reproduce as soon as she is born. Logical, है ना? You want her to reproduce when? At puberty. So at puberty, with the help of LH hormone, meiosis 1 resumes, and it releases, the primary oocyte will release. So always we all know that meiosis 1 is a reduction division. Number of chromosomes will become half. So primary oocyte will now first release one small cell called first polar body. So 10 to 12 hours prior to ovulation, it releases first polar body. And at ovulation, it releases secondary oocyte. Now I want you people to tell me, what is the other name for secondary oocyte? What is the other name for secondary oocyte? Think and answer. Okay? Now what happened? We were waiting till puberty. So primary oocyte was arrested in prophase of meiosis 1. So how you can remember is, primary oocyte, everything will be in first. So primary oocyte is arrested in which phase? Prophase. That is a first phase. So we have prophase, metaphase, anaphase, telophase, right? So primary oocyte is arrested in first phase. Primary oocyte is arrested in first phase of which meiosis? First meiosis. And it is releasing which polar body? First polar body. So remember, everything of primary oocyte is first. Okay? Very good. Excellent. So yes, secondary oocyte is nothing but ovum. So secondary oocyte is arrested in, now this ovum will wait for a proper dulha. So it will undergo further division only if the sperm comes. Otherwise it will undergo atresia. So secondary oocyte is arrested in, now remember, secondary oocyte, everything will be in second. So secondary oocyte, which phase it will get arrested? What is the second phase? Metaphase. So it is arrested in metaphase of which meiosis? Meiosis 2. So only if the sperm comes and fertilization takes place, then it will complete the meiosis 2. So at fertilization, female pronuclei is released. After fertilization, second polar body is released. So I told you, women are complicated. So I think you understand now, because spermatogenesis was tuck. and millions. But here only one ovum and atak it is forming, right? So quickly write this. We'll once again revise it so that it registers in our brain. So first we have oogonium. This oogonium will undergo mitosis to form primary oocyte. Then suddenly what happens? The granulosa cells secrete meiosis inhibiting factor. So because of the meiosis inhibiting factor, the primary oocyte is arrested in diplotin stage of prophase of meiosis 1. At puberty, with the help of which hormone? With the help of LH. Meiosis 1 will resume 10 to 12 hours prior to ovulation. First polar body is released, and at ovulation, secondary oocyte, that is the ovum, is released. This secondary oocyte is arrested in metaphase of meiosis 2. The secondary oocyte is arrested in metaphase of meiosis 2, right? At fertilization, it releases female pronuclei, and after fertilization, it releases second polar body. Now, how do you differentiate between ovum and female pronuclei? Ovum will have only one polar body in the perivitaline space, whereas female pronuclei will have two polar bodies in the perivitaline space. So now the sperm and oogonium both are ready, right? Sperm and ovum is ready. Now what happens further? Let us see. So I want to use this diagram to explain the further steps. So if you observe here, all the sperms are getting attached to the oocyte wall. And this wall of the oocyte is called as zona pellucida. The sperm head will produce hyaluronidase enzyme. From the acrosome of the sperm, there will be release of hyaluronidase enzyme. This hyaluronidase enzyme will break the zona pellucida, and that is called as acrosomal reaction. That is called as acrosomal reaction. So what is acrosomal reaction? So acrosomal reaction is acrosome of the sperms release hyaluronidase to dissolute zona pellucida. So for acrosomal reaction is done by multiple sperms. To be frank, hundreds of the sperms. I told you only 2 million will cross the cervix. No, after that only hundreds, some 100, 200 like that sperms only can reach the zona pellucida. Okay, so these hundreds of the sperms are causing acrosomal reaction where they will try to dissolute the zona pellucida. After that, how many sperms will enter the perivitaline space of the ovum? Only one sperm nucleus, that too not the entire sperm. It is only the nucleus which enters the perivitaline space. See, this is the sperm nucleus. So this sperm nucleus, when enters the perivitaline space, can you see there are some granules called cortical granules? These cortical granules are released. And what will they do? They will again cause hardening of the zona pellucida. Now why do they cause again hardening of the zona pellucida? So that is called as cortical reaction. So after acrosomal reaction, the next reaction what we have is cortical reaction. So cortical reaction is after entry of one sperm nucleus into perivitelline space, yes, excellent, NASA. To prevent the polyspermy, we have cortical reaction. So after entry of one sperm nucleus into perivitelline space, cortical granules released, and this leads to hardening of zona pellucida. And this mainly occurs to prevent polyspermy, and this is mainly occurring to prevent the polyspermy. So can you tell me what is the order which we have seen in the sperms? So sperms will undergo first spermatogenesis, then the spermiogenesis, then they will have hypermotility of the sperms is called as capacitation. So then they'll undergo capacitation, then they will undergo actrosomal reaction, then they will undergo cortical reaction. So release of the cortical granules is called cortical reaction, and hardening of the zona pellucida is called as actually zona reaction. So cortical granules are released and there will be hardening of zona pellucida, which we call it as zona reaction. And this zona reaction is mainly occurring because of the to prevent the polyspermy. So cortical granules are present already just below the perivitelline space. Can you see the cortical granules? So they are present. It is released by the ovum. Cortical granules are released by the ovum. They are present in the ovum, in the perivitelline space. So then they will be released outside like this. Can you see how they are released outside? So these are released outside. So first they will be present in they will be present like this, and as soon as one sperm nucleus will enter, they will be coming out from the capsule. Okay. Right. Now some more points I want to tell you here is at 5th month of intrauterine life. At 5th month of intrauterine life, I'll take all your queries once I finish this topic, just another 10 minutes. So at 5th month of intrauterine life, you have around 5 to 6 million primary oocytes. At birth, these 5 to 6 million primary oocytes will become, at birth, these 5 to 6 million primary oocytes will become 1 to 2 million. Among these 1 to 2 million, only 4 to 5 lakhs of primary oocytes are present at puberty. And in that 4 to 5 lakhs also, only 400 mature throughout the woman life. Only 400 have the capacity to become the ovum. At menopause, we still have 1000 primary oocytes, but they don't have the capability to become the ovum. So at menopause, we have 1000 primary oocytes, but they don't have the capacity to become the ovum. So what will happen if all our 400 primary oocytes will get depleted? What do you call that as? When all our 400 primary oocytes get depleted, what do you call that as? When all our 400 primary oocytes gets completed, what do you call that as? Yes? So when all our 400 primary oocytes get depleted, we call it as menopause. Menopause. So see, that is why woman has a very narrow reproductive life. So as soon as all this 400 gets depleted, we'll call it as, yes, we'll call it as menopause. So that is why there is ideal age for the woman to get married and have kids. It's all true because we are having very limited capacity, and each cycle may we almost use around 15 to 18 primary oocytes, in which only one will become the dominant follicle or the ovum, right? Okay, so that finishes the spermatogenesis and oogenesis. Now you can ask me your queries before I start with the fertilization. Yes, female pronucleus has only one nuclei and it has two polar bodies in the perivitaline space. So if you have any query regarding the spermatogenesis and oogenesis, feel free to ask. Then I'm going to start with the fertilization. Right. So I'll start with the fertilization now. So fertilization. So now Dulha Dulhan both are ready. So now the milan of the Dulha and Dulhan, right? So fertilization is the fusion of male and female pronuclei. So where does this fertilization takes place? So fertilization takes place in the fertilization takes place in ampulla of the fallopian tube. So fertilization takes place in the ampulla of the fallopian tube. Okay. Now after the fertilization takes place, you have a zygote. You have a zygote, right? So zygote will further divide into 2 cell, 4 cell, 8 cell, and then it becomes finally one 16 celled, that's called morula, right? So zygote will further divide into 2 cell, 4 cell, 8 celled, and then finally day 3 post fertilization you have 16 celled mulberry like morula. Day 3 to day 4 morula enters the uterine cavity. Day 3 to day 4 morula will enter the uterine cavity. So the main question MCQ which was asked from the previous topic is, I already told you, the sequence of spermatogenesis has been asked as an MCQ, right? Only that has been asked as an MCQ. And I also have the MCQs after this entire topic we'll be discussing. After every topic we have MCQ discussion, okay? So day 5, this morula will become blastocyst, fluid starts entering into the morula. So blastocyst is 58 celled. Now I'm not going to draw exact number of cells, but it is actually 58 celled. 53 cells form outer covering, which is called as trophoblast. So 53 cells will form trophoblast and 5 cells will become inner cell mass. 5 cells will become inner cell mass. Okay, this inner cell mass in future will become the embryo, and this trophoblast in future will become the placenta. So blastocyst is completely 58 cells. In that 53 cells are trophoblast, 5 cells are inner cell mass, that is embryo. Okay? So I actually can just give you a brief key how does this differentiate into and all. So just let me just show you. So if you observe this picture, this is the blastocyst. So you have 5 cells which are becoming the inner cell mass and the rest of the cells are becoming the trophoblast. So this inner cell mass will further divide into epiblast and hypoblast. So this inner cell mass will further divide into epiblast and hypoblast. See, this is nothing but your embryology, but I'm just giving you a brief here, that's all. So this epiblast and hypoblast this epiblast will again have one cavity developed inside it. And that is nothing but the amniotic cavity, guys. This hypoblast will form another cavity below, and that is called as yolk sac. So amniotic cavity and yolk sac, when you actually see on a USG, they will look like two blebs, and that is called as double bleb sign. This has been asked as an MCQ, guys. So what forms the double bleb sign on USG? So double bleb sign on USG is by amniotic cavity plus yolk sac. Double bleb sign is by amniotic cavity plus yolk sac on USG. So double bleb sign is amniotic cavity plus yolk sac on USG. Okay. Do you know what is double bubble sign? If anybody knows what is double bubble sign, you can write it in the comment box. Okay. So what did I discuss now? So the inner cell mass will further divide into epiblast and hypoblast. Epiblast ke andar there will be one cavity developed, that is called as amniotic cavity. Hypoblast also will have one more cavity, that is called as yolk sac. Amniotic cavity and yolk sac on USG will look like two blebs, which we call it as double bleb sign. All the USG images I have put it in the last of your PDF. So you know PDF I have curated in, I have mainly sent you the PDF for your reference for images. And if somebody is like writing online or writing on that, yes, you have both ways. That's the advantage. And I tried to keep all the images also in the last all USG images. Okay? Very good. Double bubble sign is seen in duodenal atresia. So never get confused in the exam. Double bleb sign is amniotic cavity plus yolk sac, whereas double bubble sign is duodenal atresia. Now this epiblast and hypoblast will further form into ectoderm, endoderm and mesoderm. This epiblast and hypoblast itself will further divide into ectoderm, endoderm and mesoderm. And that ectoderm, endoderm and mesoderm will give rise to all other structures which you know, right? So this is how the different structures develop. So we all know that gut is developed from the endoderm, muscle is developed from the mesoderm, skin developed from ectoderm. So this is how it all happens. Okay. So day 5, apart from the blastocyst formation, there is one more thing happening, guys. So all this time blastocyst is present inside the zona pellucida. So day 5 में blastocyst will be released out from the zona pellucida, and that is called as zona hatching. So what is the second event which is happening on day 5? So day 5 you are also having the zona hatching. Okay. Day 6. So day 5 there are two events. One is blastocyst is formed. Second is zona pellucida dissolution. That is called as zona hatching. After the zona pellucida will come out, day 6 May, this blastocyst will get implanted. So day 6 implantation begins. Day 6 implantation begins. Day 8, trophoblast is there, no? That trophoblast will further divide into outer syncytial trophoblast. Trophoblast differentiates into outer syncytial trophoblast and inner cytotrophoblast. This is the one which will actually become the placenta, guys, this syncytial and cytotrophoblast. And when they are becoming the placenta, these only we call them as chorionic villi. We give them name as chorionic villi. The syncytial and cytotrophoblast together we call it as chorionic villi. Okay. So we have inner cytotrophoblast. Day 10 to day 11. Implantation ends. Day 10 to day 11 implantation ends. Okay, so can we quickly I'll quickly repeat all the day wise events, guys, so just monitor it. So what did I tell you? First, all these are after post fertilization. All these are post fertilization days, right? If in the MCQ they ask you post LMP, when is the blastocyst formed? Post LMP, what will be your answer? Will it be day 5 or will it be something else? So then it will be day 19. Day 19, guys. See, always if it has to be taken from LMP, you have to add 2 more weeks extra. You have to add 2 more weeks extra, right? Okay. So day 3, morula is formed. Day 3 to day 4, morula enters the uterine cavity. Day 5, blastocyst is formed. Day 5, zona hatching also takes place. After day 5, zona hatching, day 6, implantation will begin. Day 8, trophoblast will differentiate into outer syncytial and inner cytotrophoblast. Day 10 to day 11, implantation will end. Okay. Now one more point you have here. So at the time of implantation, you will have some amount of minimal pervaginal bleeding, and that minimal pervaginal bleeding is called as implantation bleeding, which is completely physiological and not to be worried. But this can act as a differential diagnosis for. So what I'm trying to say here is, day 10 to day 11, minimal pervaginal bleeding can occur. And this we call it as implantation bleeding. It is self-limiting, it will subside by itself. The differential diagnosis for this is we can suspect it to be abortion. So any first trimester bleeding, you always will suspect abortion. But the thing is that this is self-limiting, this will stop. But abortion ka bleeding will not stop. Okay. So that's about the fertilization. Now we'll go about the implantation. So the type of implantation which we have in human beings is called as interstitial implantation. Interstitial. That is, it doesn't go deep, it is in the superficial itself. So which layer of the uterus implantation takes place? So in which layer of the uterus implantation takes place? Yeah. So in endometrium. But in pregnancy, we don't call it as endometrium, we call it as decidua. We call it as decidua, right? So interstitial implantation takes place in the decidua. So the most common site of implantation is posterior wall, upper two-third, body of the uterus. Posterior wall, upper two-third, body of the uterus. Okay. And the steps of implantation are, first it will just get attached to the endometrium. That's called apposition. Then it goes into the endometrial epithelium. Then it invades into the endometrial epithelium. So the first step is apposition. Just write what I'm writing. So first step is apposition. So apposition is where it is just getting adherent to the, where it is just sticking to the endometrium. And this is mainly by pinopods. Can you see this red color one? Small projections. Those projections help in apposition. So apposition is mainly by pinopods. Okay. Next, coming to the second step after apposition is adhesion. So adhesion may, it will go into the endometrial epithelium. So adhesion, so in adhesion we have the integrins, selectins, proteoglycans and fibronectins. So proteoglycans and fibronectins. So all these are helping in the adhesion. Okay. After adhesion, we have invasion. See, adhesion may it is going only up to endometrial epithelium. Invasion, it will go into endometrial stroma. So endometrial stroma, these are mainly helped by the, so see, can you see the cyto and syncytial trophoplasts are making finger-like projections? So these finger-like projections, we are going to call it as chorionic villi. So this invasion is possible by proteolytic enzymes like serinoproteases, metalloproteases and collagenases. So invasion is by proteolytic enzymes, that is serinoproteases, metalloproteases and collagenases. Okay. Can I change the slide? So what were the three steps? Apposition, adhesion, invasion. Just remember, apposition is by pinopods, adhesion is by all ases, fibronectases, proteoglycan, fibronectins, selectins, integrins. So all ins. Invasion is by serinoproteases, metalloproteases, collagenases. Okay. Now, this is important. Next point is important. So, after the implantation takes place, there is anatomical Anatomical, remember this word guys, it is anatomical division of decidua will take place. So there will be anatomical division of the decidua, and based on those anatomical division of decidua we have three types of decidua. Okay, first and foremost, which is the hormone which is forming the decidualization of the endometrium? Progesterone. Progesterone is the hero hormone guys. So anatomical classification of the decidua. So the part of the decidua, I'm going to just magnify this so that you can see it better. The part of the decidua which is lying below the blastocyst, this decidua is called as it is present below, you're going to call this as decidua basalis. The part of the decidua which is going to be covering the fetus, this part of the decidua which is covering the fetus, this decidua is called as decidua capsularis. And the part of the decidua which has been covering the entire uterine cavity, this one, this part is called as decidua parietalis. So what are the three parts I told you now? So I told you the part of the decidia, it is very simple, yeah. It is present below, so basalis. It is covering capsularis. The rest of the uterine cavity is parietalis. So basalis, capsularis, parietalis. Now please remember one more point, guys. When you see this in ultrasound, you will feel that gestational sac is covered by two rings. And that is why we call it as also double decidual sign. This has been asked as an MCQ, guys. What is double decidual sign has been asked as an MCQ, and they've asked what layers form the double decidual sign. So remember the mnemonic that double decidual sign is formed by capsularis and parietalis. So double decidual sign is by decidua capsularis plus decidia parietalis. So double decidual sign is by decidia capsularis and decidia parietalis. Can I get a thumbs up if you all understood what is basalis, what is capsularis, and what is parietalis? Okay, now next thing is that so if you actually observe, even the fetus is covered by two layers. The layer which is covering the fetus, the inner covering of the fetus is called as amnion. We all know that baby is covered by amniotic sac. The green one, what you are seeing, is called as chorion. That is nothing but the trophoblast. So there is some amount of trophoblast which is not forming any finger-like projection. So that part of the trophoblast which is not forming any finger-like projections, that is called as chorion levae. Chorion levae. And the chorion which is forming finger-like projections, that is called as chorion frondosum. Chorion frondosum. So this is chorion frondosum. And this is chorion levae. Okay. So this is the chorion. So chorion frondosum can also be called as chorionic villi. The chorion which is not taking part in anything is called as chorion levae. Okay. Now, we all know that baby will not always be so small. Baby will keep growing. When baby grows, the decidia capsularis and parietalis, which were separate all this time, will become one, and that we call it as decidia vera. See, here we had, see, this is decidia vera. We don't have separate capsularis and parietalis. So when is decidia vera formed? At 16 weeks. So if you see here, there we have capsularis and parietalis separate in this picture. Capsularis and parietalis separate in this picture. But here everything has been fused and has become one. That is called as decidia vera. So at 14 to 16 weeks of gestation, decidia capsularis and parietalis fuse together, and this we call it as decidia vera. Right. So at 14 to 16 weeks of gestation, decidia capsularis and parietalis both will become chipku, and then we call it as decidia vera. So can you tell me one point, guys? Okay, what is double decidual sign? So on USG, you will see around gestational sac two rings formed because of capsularis and parietalis. That we call it as double decidual sign. Yes, double decidual sign is a sign of intrauterine pregnancy. It does not confirm pregnancy. It confirms that it is a intrauterine pregnancy. See, confirming pregnancy can be with the UPT also. But double decidual sign tells that yes, the bacha is inside the uterus only. Okay. Now I'll show you one image, guys. I'll show you the images actually. So what I was trying to tell you was this one. See. So this is the gestational sac. This black color, what you're seeing is the gestational sac. So now you're seeing around the gestational sac two rings, right? Can you see two round rings? So that is nothing but the decidia capsularis and parietalis. And this picture tells us that this is a double decidual sign. All of you understood the double decidual sign? So this double decidual sign is a sign of intrauterine pregnancy. The first sign of intrauterine pregnancy is intradecidual sign, guys. The first sign of intrauterine pregnancy is intradecidual sign. That is, gestational sac will be eccentric in position. So, simple fundaya. If you are parking a car, you will park in the center or will you park in the parking lanes? Parking lanes. Here also bacha will be parked in the lane, not in the center. So, intradecidual sign is nothing but gestational sac is eccentric in position. One more sign I taught you, know, that also all these pictures are there already in your PDF. Don't worry at all. But I kept it in the last so that it will be easy for you to revise. So I told you one more sign, no, that is double bleb sign. I'll show you the double bleb sign. So this is the double bleb sign. So can you see here? There is a yolk sac and amniotic sac. So these two sacs are forming two blebs. So that why we call it as double bleb sign. I'll just magnify it so you can see it more better. So two small bubbles type blebs like it is. Excellent, Gaia. I wanted to ask the same question. So can we see so till how many weeks of gestation we can see double decidual sign? So till how many weeks can we see the double decidual sign? So double decidual sign can be seen only till 16 weeks. It is an early sign of pregnancy. You cannot see it beyond 14 to 16 weeks. Very good. So in second trimester, you will not see all double decidual sign and all anything. Right? Next. Very good. So Darshan has a question which is very valid. So do we see double decidual sign in ectopic pregnancy? No. That is what. So to differentiate between double decidual sign, to differentiate between intrauterine pregnancy and ectopic pregnancy, you can use this double decidual sign. So if double decidual sign is present, it is an intrauterine pregnancy. If there is no double decidual sign, you are dealing with an ectopic pregnancy. Right? Very, very good. This is how you have to coordinate. Excellent. This is how you have to think. That's very good. Okay, so I hope you all understood all the images also. Now I'll quickly answer this image. What is number 3? So this finishes the topic. It is all MCQs. So I want all of you to be on your fingers and keep answering the MCQs now. So what is number 3 here? Number 3. So number 3 is the pink one. Pink one is Decidia basalis. Right? So number 1. What is number 1 now? So number 3 is Decidia basalis. All of you have answered correct. That's correct. What is number 1 now? So number 1 is Decidia paritalis. What is number 2? Covering the fetus. So number 2 is Decidia. Excellent. Number 2 is Decidia capsularis. What is number 4, guys? What is number 4? What is number 4? So number 4, anybody can answer number 4? So number 4 is, excellent Aisha, number 4 is the uterine cavity. So number 4 is the uterine cavity, right? Now let us see the next picture. So let us see the next picture. So what is number 6? So the purple one which is forming finger-like projections. What is number 6? So what is number 6? So number 6 is the chorion frondosum. So number 6 is the chorion frondosum or the chorionic villi, right? So what is number 5? So number 5 is the chorion which is not forming any finger-like projection. So number 5 is the chorion levae. So number 5 is the chorion levae. Number 5 is chorion levae. Number 8. So number 8 is Decidia paritalis and Decidia capsularis and Decidia paritalis. So number 8, the Decidia capsularis and paritalis fuse together. That is number 8 is Decidia vera. And number 7 is the amniotic cavity. Number 7 is the amniotic cavity. Okay. Yes, number 7 is the amniotic cavity. Number 8 is the decidia vera. Number 5 is the chorionic levee. So I hope you all understood these pictures. Now we will do some MCQs, guys. Yeah. So intrauterine periods may the ovular or germinal period is fertilization to 2 weeks, whereas embryonic period is 3 weeks to 8 weeks, and fetal period is more than 8 weeks till delivery. So during embryonic period, we normally have the organogenesis, that is development of the organs of the fetus. And this is the time period, if you have exposure to the teratogens, there will be teratogenicity, right? So most crucial for us is the embryonic period, So very good, Abja. Excellent. So in the embryonic period, we have the organogenesis taking place. And during this organogenesis, if you are having any exposure to teratogen, we have different abnormalities or malformations in the fetus, right? So the first trimester is most important, where you should not give any unwanted drugs. So for example, can you tell me what is the abnormality which we see with the lithium? This has been asked as an MCQ many times. So what is the abnormality which we see with the help of lithium? So with lithium we see Epstein's anomaly. So with lithium we see Epstein's anomaly, right? Very good, Rishabh. And next, among all the anti-epileptic drugs, valproate has the maximum teratogenicity. So valproate is associated with cleft lip, cleft palate, and neural tube defects. So valproate is associated with cleft lip, cleft palate, and neural tube defects. Okay, right? Next we have the so after lithium, valproate. Next we have, so anti-epileptic of choice in pregnancy is levetiracetam and lamotrigine, guys. So anti-epileptic of choice in pregnancy is levetiracetam and lamotrigine, right? Warfarin causes Contradi syndrome. Again, we'll have midline facial defects and epiphysis also. They'll see stippling in the Contradi syndrome, right? So basically, all the teratogens are going to affect in the first trimester. Okay. Right, now let us see one more question. So do the sequential arrangement of the following. So you have to write the sequential arrangement. Don't tell one after the other. Write the sequential arrangement and then type it. That will be easy for me. You write the sequential arrangement and type. So Saundarya, if you wait, you don't require to confirm the intra. See, after 16 weeks, we cannot identify because we don't have double decidual sign. So this double decidual sign will appear as early as 4 to 5 weeks itself. So you don't require to wait till 14 to 16 weeks. Indeed, double decidual sign disappears after 14 to 16 weeks, right? So I have an answer here. I have an option of 5, 1, 2, 3, 4. Let us see whether it's correct or not. So first we have the oogonium. Yes, excellent. After oogonium, it is a primary oocyte. So yes, after the oogonium, primary oocyte. Then we have the, so this is not correct. So after the oogonium, primary oocyte is correct. After the primary oocyte, which is first being released? Is it the secondary oocyte first being released, or the first polar body which is first going to be released? If you remember, what did I write? 10 to 12 hours prior to ovulation, first polar body is released, and at ovulation, secondary oocyte or the ovum is released. So first should be first polar body and then the secondary oocyte. So the answer here should be 5, 1, 3. First polar body and then the secondary oocyte. Then actually we should have the female pronuclear and then the second polar body. So it is 5, 1, 3, 2, 4. All of you understood? Whoever has done the mistake of 5, 1, 2, 5, 1, 2, 3, 4. Did you understand? It is 5, 1, 3, 2, 4 because the first polar body is released first and followed by secondary oocyte. Okay? Remember that. Now here more than one answer is correct. So choose the combination which all answers are correct and write in the comment box. So primary oocyte is formed after single meiotic division. It is maximum in number in 5th month old fetus. It is in prophase arrest. It is also called as blastocyst. So primary oocyte is formed after single meiotic division is a wrong statement. It is not formed after single meiotic division. It is formed after single mitotic division. So the first sentence is wrong. So I have the answer here 2 and 3 by Spurti. Let us see. So yes, first option is wrong. So primary oocyte is maximum in 5th month old fetus is absolutely correct because it is around 6 to 7 million in 5th month old fetus is absolutely correct. Excellent. Primary oocyte is in prophase arrest. Yeah, I told you primary oocyte everything was in first. So it is also in prophase arrest. We don't call primary oocyte as blastocyst. So this is wrong. So the answer here is 2 and 3. That's also correct. Right. Very good. Now again here zygote reaches the uterine cavity as 32 cell, 16 cell, 8 cell, 2 cell. So zygote reaches the uterine cavity as 16 cell morula. 16 cell morula. So the answer here is 2. Now again here more than one option is correct. Choose which is the correct options and type it again. I told you one simple funda. Primary oocyte, remember everything first. Secondary oocyte, remember everything second. So primary oocyte arrests in prophase of first meiotic division. This is correct, है ना? Because primary oocyte, prophase, first meiotic. I told you primary oocyte everything in the first. So that is a correct option, right? So I have here 1 and 4. And I have Gaya 1, 4, 5. Okay. Let us see whether you have answered it correct or not. So the first option is absolutely correct. Primary oocyte arrests in prophase of first meiotic division is correct. I told you primary oocyte, remember everything in first phase. So primary oocyte arrests in prophase of first meiotic division is correct. So primary oocyte arrests in prophase of second meiotic division, this is wrong. Secondary oocyte arrests in metaphase of first meiotic division? No. So secondary oocyte is metaphase, but which meiotic division? Second meiotic division, not first meiotic division. So this is wrong. Secondary oocyte arrests in metaphase of second meiotic division? Yes. I told you secondary oocyte everything second. So that's why it is easy to remember that way. Okay. First polar body is extruded during first meiotic division of the primary oocyte? Yes. So first polar body is extruded during the first meiotic division of primary oocyte is also correct. So you all are correct. The answer is 1, 4, 5. So this finishes our first topic, that is basics of reproduction, where we have learned the gametogenesis, that is spermatogenesis, oogenesis, and we have learned the implantation and fertilization, right? So we have solved the MCQs also here. Let's go to the next topic, that is placenta. You know, the simple description of the placenta has been asked as an MCQ. And I think all of you would have already, all of you also would have seen placenta in your labor room, no? So human placenta is discoid, shape of the placenta is like a disc. It is hemocroidal, half bled from the mother, half bled from the fetus, and it sheds off post delivery. So that's why it's also called as deciduate. So it is discoid, it is hemocroidal, and it is deciduate. There was last year there was a question from the placenta in the INECET. So human placenta is discoid, hemocroidal, and deciduate. So placenta is made up of two components. We have chorion frondosum. Fetal component is chorion frondosum. Maternal component is decidia basalis. So you remember that decidia basalis into that finger-like projections were formed. So this finger-like projections into decidia basalis is nothing but the placenta. So from the fetal component it is the chorion frondosum, and the maternal component it is the decidia basalis, right? So these two combinations make the placenta. So you all would have seen in your labor room placenta. So fetal surface of the placenta will be smooth and glistening. Why it is smooth and glistening? Because it is covered by amnion. So fetal surface is smooth, glistening, covered by amnion. And in the center of the fetal surface, we will have the umbilical cord. So we have the umbilical cord in the center. Right? Next, maternal surface is divided into multiple lobes. It is rough, pink, shaggy, divided into multiple lobes. What do you call each lobe as? Each lobe is called as cotyledon. Multiple lobe cotyledons. I always used to presume that there are around 15 to 20 cotyledons, but the new Williams gives it as 4 to 28. Okay, 4 to 28 cotyledons. So what is important here and what has been asked as an MCQ is the description of the placenta. That is, it is discoid, it is hemocroidal, it is deciduate. So this part has been asked as an MCQ, and the normal terminology of the placenta. How is the placenta at term? This also has been asked as an MCQ, guys. So you should be knowing this. So at term, placenta diameter is 15 to 20 centimeters. It's usually around 2.5 centimeters thick in the center. It weighs around 500 grams. It weighs around 500 grams. So the polygonal structures which you are seeing here, no, these parts are called cotyledons. I'll show you one video where you can see them clearly. What are these cotyledons? What am I telling? All this chorionic frondosum. I have one beautiful video. I'll be playing it now for you all. Okay? So it is around 15 to 20 centimeters in diameter. In the center, it is around 2.5 centimeters in thickness. It weighs around 500 grams. Baby weight to placental weight is 6:1. So for example, if baby is 3 kgs, placenta will be 500 grams. So baby weight to placental weight is 6:1. At 17 weeks, baby weight and placenta weight both will be equal, 1:1. So at 17 weeks, baby weight to placental weight will be 1:1. Right? So if you have finished writing this, first I'll just explain you in a 2D manner how is this placenta developing. Then I'll show you the video. Okay? So the development of placenta. So basically this trophoblasts, the syncytial and cytotrophoblasts, they will make finger-like projections. Okay. So first we have the primary villi. So primary villi is formed on day 12. So we all know that from maternal side we have the deciduum basalis. What is the layer which was present below the deciduum basalis? Was it syncytiotropoblast or cytotropoblast? So if you remember, I told you it is outer. So it is outer syncytio and inner cytotrophoblast, right? So we have outer syncytio. In that syncytiotrophoblast, you will have lacunae being developed. Means spaces will develop. Okay? Very good. It is outer syncytio. See, syncytio means all the nuclei are joined with each other. They are not like separate cells. So in the outer syncytio, you will have lacunae being developed. And inner cytotrophoblast is there, no? This cytotrophoblast will make finger-like projections. This is the primary villi or the solid villi. And on day 15, spiral arteries enter into this intervillar space and fill its blood. So day 15, spiral arteries enter into intervillar space. Okay. So basically, if somebody asks you when is the uteroplacental circulation established, what should be your answer? See, there in the question itself, you will have the explanation. Uteroplacental circulation. So on which day the spiral arteries are entering into the intervillar space? Day 15. So day 15 you are having the uteroplacental circulation being established, right? So this is about the primary villi. Now we'll go for the secondary villi. Very good, Humera, excellent. So now we'll go to the secondary villi. Secondary villi also same like primary villi itself. So secondary villi is formed on day 16. Only thing extra in the secondary villi is extra embryonic mesoderm also enters into it. So first deciduum basalis, then you have the intervillar space, then you have the syncytial cytotrophoblast. Now one thing extra is extra embryonic mesoderm. So this is the secondary villi. So I'm going to write the names. So deciduum basalis, syncytiotrophoblast, cytotrophoblast, and the green one is extra embryonic mesoderm. Extra embryonic mesoderm. So this forms the secondary villi. So what is the only thing which is extra in the extra embryonic mesoderm? Secondary villi, it is the extra embryonic mesoderm. Okay. Now comes the tertiary villi. So tertiary villi is formed on day tertiary villi is formed on day 17 to day 18. So same everything. Now fetal capillaries also will enter into it. So first is the decidia basalis. So first is the decidia basalis. After decidia basalis, you have the same syncytiotrophoblast into which the spiral arteries will enter. Then we have the cytotrophoblast. Now what the cytotrophoblast will do is they'll form shell, guys, cytotrophoblastic shell. Apart from making finger-like projections, they also form cytotrophoblastic shells. One lining preventing the this finger-like projections to go beyond. Okay. And then we had the extraembryonic mesoderm. Now into this extraembryonic mesoderm, fetal capillaries will enter. And this is the placenta, right? So let's write the names. Syncytio, cyto, extraembryonic mesoderm, and fetal capillaries. Now I'll show you the video of what I have just drew here. So I hope you all also finished drawing this. Can I change this? So I'll show the video now of what I was going on speaking. Okay, I cannot play the video in the YouTube, I guess. So I'm sending you the video. So I've sent you the video, guys. I've sent you the video. So I want you to just have one look on the video. We cannot play that video because this session through this session. So that's the reason why we'll not be able to. But you can see there. You can see there in the Telegram group. So if you're seeing, you have that cyto and syncytiotrophoblast. So just keep seeing there. I'll just explain as per that same video which you're all seeing. First and foremost, give me a thumbs up if you're all able to see the video. Those who are watching the session in the YouTube, you can see that video in my Telegram group, which is Dr. Ramyasree Obgyn Pack. Okay. Now all of us will simultaneously watch it. Right. So if you're seeing the video, so you're seeing that there is syncytio and cytotrophoblast, right? So this cytotrophoblast is producing some enzymes to cause that lacunae in the syncytiotrophoblast. And then you're seeing that there is the spiral arteries entering into the entering into those lacunae. So you're all able to see that spiral arteries are entering into those lacunae, right? So can you see that spiral arteries blood entering into the lacunae, right? So there are being proteolytic enzymes being released, and because of which there will be lacunae formation in which layer of the placenta? In the syncytiotrophoblast of the placenta. And into that syncytiotrophoblast, you have the spiral arteries entering. So this lacunar network will be present throughout it will be present. So beautiful, no? And then you are going to observe that, so only when cytotrophoblast is making finger-like projection, that we call it as primary villi. When extraembryonic mesoderm also entering into it, we call it as secondary villi. So now what is forming is the primary villi. Only the cytotrophoblast is making finger-like projections, right? And then the extraembryonic mesoderm also will enter into it. So when extraembryonic mesoderm enters into it, we call it as secondary villi, right? And then the fetal capillaries enter into it, and then that we call it as tertiary villi. And I told you that during tertiary villi, cytotrophoblast will make one shell that is called as cytotrophoblastic shell. Those who are going to watch my video later, so I am explaining them the video which I was not able to play here because I cannot play it on YouTube. So this is actually the placenta, how it looks like, guys. So you have in the middle those stems, and in the middle, then in between them you have the fetal blood running. So through the umbilical cord, we have the umbilical artery and umbilical vein. So can you see in the villi? In the villi, you have the umbilical vessels going, and in the intervillar space, you have the fetal maternal blood running. So that is how beautiful. So in that intervillar space, it is the fetal maternal blood, and in the villus, it is the fetal blood which is running. Right? So there is no mixing of blood. You'll also see the cotyledons. You asked me what is cotyledons, no? So now they'll show you the maternal surface also. So those projections what we are seeing, that is the cotyledon, into which spiral arteries and spiral vein, endometrial veins are running. So this is the fetal surface and that is the maternal surface. So you all understood the development of placenta now? So you all understood the development of placenta, right? Okay, now answer me the layers here in this picture. So first and foremost, this picture is ulta from what I have taught. I have taught you from the deciduea to the fetus, but I have put the picture from the fetus to the deciduea. Thank you, Humera. Right. So the A, what you're seeing here is what? Okay, so the A, what you're seeing here is excellent. The A, what you're seeing here is the extra embryonic mesoderm. A is the extra embryonic mesoderm. Very good, Darshan. Excellent. So B, what you're seeing is the cytotrophoblast. That cytotrophoblast, right? So B is the cytotrophoblast. And C is the syncytiotrophoblast. C is not Decidia basalis. C is the syncytiotrophoblast. So A is the extraembryonic mesoderm, B is the cytotrophoblast. Then what is lining the intervillar space is the syncytiotrophoblast, and below that this is the cytotrophoblastic shell, and this one is the Decidia basalis. So there is no mixing of blood between the maternal and fetal. So this is the layer which is preventing the mixing of blood between fetus and maternal. And this layer is called as placental barrier, or it is also called as placental membrane. So what are all the layers which are forming the placental barrier or the placental membrane? So placental barrier from maternal to fetus, from maternal to fetus is, so from maternal I told, no, so from mother's side, from mother's blood side it is the syncytiotrophoblast. So it is from mother's blood side, it is the syncytiotrophoblast. Then followed by we have the cytotrophoblast. Then we have the extraembryonic mesoderm. Then we have the fetal capillary endothelium. So what is the function of this fetal barrier? So what is the function of this placental barrier? So the function of this placental barrier is to prevent any harmful substances from the mother to go into the fetus, like teratogens, like antibodies. Only one antibody can transfer, that is the IgG. Rest all antibodies are not able to transfer because of this placental barrier. So this is like a raksha kavach between the mother and the baby, right? So this is how the placenta develops, and this is how we have the barrier and everything, right? Now let us go to the functions of the placenta. Yeah, guys, this has been asked as an MCQ. This part has been asked. So, there are some single liners which has been asked as an MCQ from the placenta chapter. In recent NEET, you got a question that which of the following is the recent INI CET, not this year, last year. All of the following are the correct statements, except, and they gave an option that the diameter of the placenta is 15 to 20 centimeters. The thickness of the placenta is 2.5. The weight of the placenta is 500 grams. Umbilical cord contains single umbilical artery. Which is a wrong statement among these 4 statements I gave? So the wrong statement is, yeah, the 4th one is the wrong statement. Umbilical cord does not contain single umbilical artery. It contains 2 umbilical arteries, right? Okay. Now these also has been asked as an MCQ, so you should be knowing these. So the villus carries fetal blood volume of 350 ml. The intervillar space carries a maternal blood volume of 150 ml. The uteroplacental blood flow at term is 450 to 650 ml per minute. Fetal blood flow is 400 ml per minute. And uterine blood flow at term is 700 to 900 ml per minute. So the uterine blood flow at term is 700 to 900 ml per minute. So from 450 to 650, it becomes almost 700 to 900 ml per minute, guys. Okay. No, what I'm trying to say is, to the uterus, it is 700 to 900. But from the uterus to placenta, it little becomes slow. It is 450 to 650 ml. Actually, non-pregnant uterus may, the uterine blood flow is only 50 ml per minute. From 50 ml, it is becoming almost 1000 ml. So, how much? 10 times, 20 times more blood flow. Hai na? That is why if you have ever got an opportunity to see a hysterectomy specimen or cesarean section uterus. So cesarean section mein if you are seeing the uterus, the below the fallopian tube you can actually see the uterine artery. It will be full fat nagin type. Whereas in hysterectomy specimen, uterine artery you cannot see at all. But in cesarean section, uterine artery will be full fat, this much. You can see very nice tortuous vessels. Beautiful they look. Very scary. You cannot rub. Matlab, thoda here and there. If you traumatize them, gone. So now coming to the functions of placenta. So for the baby, placenta is everything. Placenta is respiratory, placenta is excretory, placenta is nutritive. For the baby, placenta is everything. So placenta helps in transfer of the gases, nutrients, and waste products. So it is respiratory, it is nutritive, and it is excretory. So respiratory, it gives oxygen and takes the carbon dioxide. So oxygen delivery occurs at a rate of 8 ml per kg of fetal weight per minute. So that is why it is very important that we maintain a feto-placental blood flow of 400 ml per minute. Now, nutrition is mainly by glucose. So glucose is transferred to the fetus by facilitated diffusion using GLUT1 and GLUT3 receptors. Amino acids are also transferred from the mother to the fetus. Lipids have dual origin, guys. In the first and second trimester, lipids are transferred from mother only to the fetus. But in third trimester, baby can also produce its own fatty acids. So lipids have dual origin. Okay. So in early pregnancy, lipids are transferred to the fetus. But in late pregnancy, fat is synthesized by the baby also. So it has a dual origin. Right. So the advantage of taking the printout is you don't require to write all. Some places what I did in this PDF is I have kept the written information, where it is. So, you don't require to write everything when you have a PDF with you. So if you have taken the printout today already, very good. I think you're enjoying it writing in the PDF. I hope I try to make it very organized, to be frank. So if you have not taken the printout today, don't worry. Tomorrow you can take it. At least for tomorrow and day after tomorrow's session, you will be able to use it. But there are few things which are extra. We'll be adding to this PDF also. Some pages I'll be adding more. That's what I'm trying to say. So coming to the immunological function. What does immunological function means? So, bacha is made up of both mother and father antigen. Then also we never reject the baby. Why we don't reject the baby? When baby is made up of both mother and father, when father is a new antigen to me, why don't I reject the baby? That is the immunological function which placenta is playing. So on the villi, there is no HLA expression. That is why we never see the fetus as a foreign body. Okay? Yes, I'll give a break. Don't worry. So on trophoblast, there is no HLA expression. Very good, Samina. So that's why we don't recognize it as a foreign body. It secretes a lot of hormones, so endocrinal. It also acts as a barrier and it produces. So it has enzymatic function and barrier function, right? So coming to the So you want a break or can I continue for another half an hour? So coming to the hormones. So there are many hormones which are secreted from the placenta. Actually, there's one full chapter. But I'm going to discuss most important hormones. I'm going to discuss most important hormones, that is HCG, HPL, progesterone, estrogen. Okay. So first, I'll just finish hormones and I'll give you a break. Only hormones will finish and then I'll give you a break. Okay. So first, let us discuss about the HCG. Yeah, I think I have a space for estrogen and progesterone before HCG. So what is human placental lactogen? So human placental lactogen, this is an anti-insulin hormone. This is an anti-insulin hormone. Okay. Another 5 minutes, I'll give you a break. Don't think about the break now. As I told, we are going to stick to the, till I'm teaching you here, stick to here, another 10-15 minutes, that's all. Okay. So human placental lactogen is an anti-insulin hormone. So this breaks the lipids. It breaks lipids to increase the glucose production. So it mainly causes the lipolysis. So this is secreted from 24 weeks and is maximum in third trimester. So this is one of the hormone which creates a diabetes like state in the patients with pregnancy. Okay, so pregnancy mein diabetogenic hormone, one of the diabetogenic hormone is HPL also. So when I'm teaching diabetes, you should tell HPL is one of the reason for the diabetes in pregnancy. Okay, right. Next, coming to the progesterone. So progesterone is produced from maternal LDL cholesterol. This is a hero hormone. Why? Because it relaxes every smooth muscle in pregnancy. Okay. Now, do we really have in pregnancy aam khane ka, khatta khane ka, all that really do we have? And like too many mood swings. If we are rowing, we are rothlu, we are laughing. All this do we really have in pregnancy, or it's just a hype created? We do have pretty mood swings. We go crazy in pregnancy. Why? Because of the progesterone. Estrogen, remember guys, estrogen is one which stabilizes the woman. Progesterone is the one which makes us crazy. So progesterone causes all those symptoms of craving, mood swings and all. So all those are there in pregnancy. And this is a main hormone in pregnancy. Why? Because it is the one which is going to cause uterine relaxation. So it causes uterine relaxation. It causes decidualization of the endometrium. Right? It helps in the alveolar growth of the breast. See, we always tell pregnant women to walk post meal. They should not lie down post meal. Why? What will happen if they lie down post meal? So this progesterone causes smooth muscle relaxation. So because of that, what will happen is when she lies down, there will be GERD. So that is why we should always ask the pregnant women to take small meals 2 hours apart, and they should walk post meal. They should not lie down because progesterone will cause sphincter relaxation, esophageal sphincter relaxation. Progesterone also causes constipation in pregnancy because of the bowel relaxation. So additional things which progesterone is causing is GERD and constipation. Basically, it relaxes every smooth muscle in pregnancy. That much you remember. So, as progesterone causes uterine relaxation, we can use progesterone for what? So, I hope you all finished writing progesterone. I'll go to the HCG. So, I'm changing the slide. So, HCG, that is human chorionic gonadotrophin. So, this human chorionic gonadotrophin is secreted from syncytiotrophoblasts. Excellent, Utkarsh. As progesterone causes uterine relaxation, you can use progesterone to prevent preterm labor. So, as progesterone causes uterine relaxation, progesterone can be used to prevent preterm labor. Okay? So, it is secreted from syncytiotrophoblasts. Hormone factory is syncytio only. So, most of the hormones are secreted from syncytiotrophoblasts. HCG has two subunits, alpha subunit, beta subunit. So alpha subunit is similar to LH, FSH and TSH. Whereas beta subunit is specific and this has luteotropic action. So it acts like luteinizing hormone. Luteotropic. So normally we all know that HCG is mainly used for to detect pregnancy. So whenever we feel that somebody is pregnant, what even laymen also, they'll get that UPT kit, urine pregnancy test kit, and if you see two lines, it means they are pregnant, right? So at the time of missed period, our beta HCG level should be 20 international units. And that UPT, what we are doing, no, that is sandwich ELISA method, guys. That is sandwich ELISA method. So beta HCG doubles every 48 hours up to 10 weeks. So among the hormones, most important where you have got MCQs is from HCG, guys. So HCG is the most important imprinting in your brain. So wherever I'm telling important, you can put a star. So beta HCG doubles every 48 hours and then it is maximum at 10 weeks. At 10 weeks, it's around 1 lakh international units per liter. And then it drops down at 16 weeks and remains as a plateau. So beta HCG is maximum at 10 weeks by 1 lakh international units. Then it drops down and remains as a plateau. Okay. So the best test to detect beta HCG is fluoroimmunoassay radioimmunoassay followed by radioimmunoassay. So what we are doing is that sandwich ELISA, that is not best. So best test is fluoroimmunoassay followed by radioimmunoassay followed by ELISA or the radiometric assay. Last is immunoradiometric assay. That much it's okay. This much you remember. Now, beta HCG can be detected in both urine and serum as early as day 8 post fertilization. Beta HCG can be detected in both urine and serum as early as day 8 post fertilization, but not by your UPT test. It is by the fluoroimmunoassay test. So why you can detect as early as day 8 post fertilization? Is there any logic or just like that? There is a logic. Who can tell me what is the logic behind detecting it as early as day 8 post fertilization? Why can we detect as early as so for this fluoroimmunoassay and radioimmunoassay, you don't require it to be 20 international units. Even at 1 international unit also it can detect pregnancy. But for our UPT, it should become 20. Excellent, Spurti. We can detect as early as day 8 because syncytial trophoblast is formed on day 8. That's why we can detect as early as day 8. Okay? Yes, very good, very good. So actually beta HCG disappears from urine 48 hours after delivery. This you don't require to remember, but yes. So it takes some time to disappear post delivery, the beta HCG. Now very important, which has been asked as an MCQ multiple times, is what are the conditions where beta HCG is raised and what are the conditions where the beta HCG is decreased. So this has been asked as an MCQ many times, so you all should know. So the HCG is increased in, you can remember with the mnemonic of mentally retarded DCH, Pagal pediatrician. So mentally retarded DCH, multiple pregnancy, RH incompatibility, Down syndrome, choriocarcinoma and hydatid form mole. So in all this, because placenta will be large. So you can detect in multiple pregnancy, RH isomerization, Down syndrome, choriocarcinoma and hydatid form mole. Now you might ask, why do we have a huge placenta in RH isoimmunization? So I'll tell you the concept here. See, RH isoimmunization mein what is happening is you have antibodies against fetal RBC, because of which hemolysis is happening in the baby. So as there is hemolysis in the baby, what will happen is the broken RBCs are not able to carry the oxygen. So there is hypoxia. Yes, right. So with respect to that hypoxia, what this placenta does is it undergoes placentomegaly, thinking that probably I should pick more oxygen. But actually, even placentomegaly won't help, but it is a compensatory mechanism for the hypoxia due to hemolysis. Okay. Ectopic may, see, the concept here is you should have a large placenta, then you'll have more HCG. Will you have in ectopic good placenta? No. So ectopic may levels of beta HCG will be less. Right. So levels of HCG are decreased in ectopic pregnancy, spontaneous abortion and Edwards syndrome. So Pagal pediatrician, mentally retarded DCH, M multiple pregnancy, R RH isomerization, D Downs, C choriocarcinoma, H hydatid form mole. Okay. Next, coming to what are the functions of this. So function, it maintains the corpus luteum, so that corpus luteum can produce progesterone till placenta takes over. So till 10 to 12 weeks. And then after 10 to 12 weeks, there will be luteoplacental shift. Placenta can produce its own progesterone. Okay, so it maintains corpus luteum. It helps in the growth and development of the umbilical cord. So umbilical cord develops from HCG helps in the development of the umbilical cord. Umbilical cord develops from connecting stalk, guys. Now, this has been asked as an MCQ in the one of the INE-CET. So this acts as a primary stimulus for the release of testosterone from the male fetus. Who can tell me the concept behind why is HCG acting as a primary stimulus for the release of testosterone from the male fetus? Twins and multiple pregnancy are same. This has been asked as an MCQ that what acts as a primary stimulus? Yes. So it acts as a primary stimulus for the release of testosterone from the male fetus because alpha subunit of HCG is similar to LH. And I told you that LH is the one which stimulates the Leydig cells to secrete testosterone. So first HCG, as it is similar to LH, will act as a primary stimulus to release the testosterone from the male fetus, right? Very good, excellent. It also has some role in immunosuppression. So that is about the HCG. So I'll just show you about the HC question now. So again, more than one option is correct here. Tell me what are all the options which are correct. So type there what are the correct options. Alpha subunit is identical to LH, FSH and TSH. It causes involution of corpus luteum, doubles in 7 to 10 days, maximum level is 60 to 70 days, detected in serum and urine 8 to 9 days after fertilization. So alpha subunit is identical to LH, FSH and TSH is correct statement. It does not cause involution of corpus luteum. It maintains the corpus luteum. It doubles in 48 hours. So this is also a wrong statement. Maximum level is seen at 60 to 70 days of gestation is correct, right? So fourth one is also correct. So it detected in serum and urine 8 to 9 days after fertilization is also correct. So what are the statements which are correct? 1, 4 and 5. Fourth also is correct, no? Maximum levels at 10 weeks. 10 weeks means 70 days, no? 1, 4, 5 are correct. So you can all go for a break and come back by 12. 5 minutes. 12:40. You can all assemble back by 12:40, guys. I think you'll get a new link. So I hope you're all enjoying the session and understanding the session, guys.